My name's Rob Cywes. I brand myself as a metabolic health specialist. And let me just get my little clicker over here. Doug asked me to talk about metabolic, the metabolic change in terms of diet for type 1. And I've changed it a little bit because we have a specific treatment protocol for our type 1s, and we're about to publish that. We're busy gathering all the data for that. So I'm going to present some of the preliminary data of that. Just this slide does represent, let me just make sure I can do this. Where's my little, oh, there it is. This slide does represent the maturation of what we do for a living. So everybody knows the SMHP, we know the food pyramid. Nutrition Network is our training course, that's our university. And now we have the Journal of Metabolic Health. Anybody interested in publishing, definitely consider them. We have our textbook and we have our practice. And my practice is myself, the physician, as well as Cheryl Fox, our a dietitian, but she's also a CDE, a certified diabetic educator, and Erin Smith, which is a psychologist and a nurse practitioner. I'm going to come to you in a second, Bubby. So that's the way I've set up my practice. Physician, dietitian, mental health specialist. And that is a foundation for us. So let's get to this guy. So please, guys, please, for any of you that are sensitive, with this next slide, please, it's a warning. Avert your eyes, close your eyes, because I'm going to show you a photograph or a series of photographs of a young child that is near death. Near death. These are horrible, horrible pictures that nobody should really see, and these are awful images. And so if you're sensitive, please avert your eyes, because what I'm about to show you is a carnivore. Go to Mama. So, obviously, I didn't realize he was going to be here, but there's the real deal. And don't let anybody ever tell you that a child cannot be raised to eat the way humans were supposed to be raised. Okay? The ketogenic lifestyle is a health choice. And we as parents can choose to raise our kids that way. If you can choose your kids, if you're Hindu or have a belief system to choose to raise your kids vegetarian, if you're Jewish or Muslim and choose to raise your kids without pork, you can choose to raise your kids without carbohydrates. And God knows they're going to face a tsunami of carbohydrates in their lives. So here's the little guy munching on a rib. There's his snack. Doesn't do it very often. Okay. This is a book that was written by somebody for children. It's called the Right Yum Yum. It's a children's book on how to eat not necessarily a carnivore, but a ketogenic diet. But here's another thing. If anybody argues with you, or if anybody says to you, well, it's so unhealthy for your kids, because we don't say that Rian is a carnivore, we say that he's gluten sensitive. That's how we've kept him. Otherwise, he would have been taken away for child abuse. But here's an interesting conundrum. Would you guys say that breast milk is the healthiest food for a child to eat? What's breast milk? Breast milk is a pure carnivore diet. It's a pure carnivore diet. It's a 100% carnivore diet. Breast milk is the only carnivore product that is dominant in saturated fat. Okay? So if carnivore was bad for us, if this way of eating was bad for us, no mammal's child should survive. It doesn't compute. But we take breast milk and we turn it upside down, and we take out the fat, there's no fiber in breast milk, we add fiber, we take out the salt, we add in polyunsaturated fatty acids, we destroy it, and then we wonder why we're fat and have diabetes. So I just threw that out there because Doug did ask me to talk about children. I'm not going to be talking about children now for a specific reason. We weren't including them in our study. But the SMHP has reached a point now where we are putting together, and I think Eric talked about this, Dr. Westman. Love Dr. Westman. I love it even better when he's wrong. But we're going to talk about type 1 diabetes management. And as part of the narrative here is how recently we have actually been able to treat type 1 diabetes correctly. Have empathy for the endocrinologists. I don't have a lot, but have empathy for the endocrinologists that are trapped in the old way of treating diabetes, and I'll explain that to you in a second. But the SMHP has come up with this document that is at least promoting the diet that you just saw that my son and that a healthy human being is raised on as an excellent foundation for people with diabetes. And I would urge you all to read the full document. How do I advance the slide? It ain't working. Can you advance the slide? So let's get right into the weeds. I know this is a very busy slide, and I'm putting on my science hat. This is my practice, JSAPA, and this is a study that was supported by Dexcom. We, over the course of about 12, 13 years, have treated 1,093 type 1 diabetics. Okay? These patients, I'm slightly biased in the study in that these patients sought me out. I didn't go out and say, hey, you got type 1 diabetes, come in here, I'll treat you. They all looked for me, so that is my stated bias. These are all patients who are motivated, looking for a second opinion, but 100% of them were already on some form of conventional therapy. Now, this is just due to a lack of time. The 1,000 patients will be published pretty soon. I have full data now on N of 200. So what you're going to hear me talk about is an N of 200 patients. It's a code of this. They're not cherry-picked or selected. It's just I'm me plowing through the data. There were 135 males and 65 females. The age range, and the age had to be cut off at 18 because my IRB won't allow me to publish or study patients under the age of 18. So my age range was 18 to 83, which is about the age of Richard Bernstein. Average age was 51. They were all type 1s, or LADA, that 1.5 or the autoimmune diabetes. And we actually have, interestingly, an extended family of monogenic diabetes, which is a form of type 1. It's a genetic form of type 1. And the minimum follow-up period was 5 years. So this is a long study. This is not your 3 weeks on a diet study. It's 5 years. Okay? By the time you've gone 5 years, it's a way of life. The time from diagnosis. So how long had they been diabetic for? Well, some of them were diagnosed by me. The patient furthest out had been diabetic for 64 years. Remember that when we talk about the history of diabetes in a few minutes. 162 patients had type 1 diabetes, 38 were antibody positive, and we test antibodies on everybody. If you haven't had your antibodies tested, test them. But 38 were antibody positive. And what's interesting is in this cohort, 41 of the 200 patients had been misdiagnosed and mistreated as type 2s. Why? Because their docs didn't do an insulin or a C-peptide. So they were on metformin and they were on a bunch of medications. They were doing very poorly because they had type 1 diabetes or a variant of type 1. The entry A1C, so when these patients were entered into the study, the average A1C was 8.9%. The range was 6.5 to 13.1. And again, by study, the cutoff on this algorithm, on this study, was 6.5. So we have patients in that 1,093 that have A1Cs below that because they've already done pretty well. But for this study, it's 6.5. So with a true diabetes diagnosis. And the highest A1C at diagnosis was 10.2 on average. At the start of the study, the first thing I did when these patients come in is I get them to wear a CGM where they can show me their CGM data, and I want to see their 7-day blood glucose average. So we're talking about A1C, but we're also talking about blood glucose, and the average blood glucose of these patients was 188. Okay? And you talk to an endocrinologist, it's okay. It's okay. Because 188 represents kind of the upper limit of what endocrinologists call time in range, 180. So they're not bothered by that. I'm like shivering here in my... Anyway, I won't tell you what my butt muscles are doing, but that scares me. And some of these patients, when we used Keto Mojo, some of these patients were in chronic DKA. That's where they live. Not a good place to be, okay? Average ketones were pretty much 0. They were 0.1 because of some of these patients. Starting BMI was 27.8, so they were overweight. They weren't enormous. We had underweight people at 17.1, all the way to morbidly obese, 45.9. And just the results will come, some of the results come later, but the BMI results during this 5-year program, the average BMI dropped from 27.8 to 24, the 17 came up to 19, and the heavy patients dropped down to 32. Not completely normal, obviously it's a range of patients, but a pretty significant decrease in size. Now here's the other part. Why is diabetes an issue? Who cares what diabetes is? This is why. This is why. Diabetes is just a number, but this is why. 2 of these patients had strokes. 2 of these patients were on dialysis. 4 of them were legally blind. 1 already had a below-knee amputation. 33 toes were missing in 12 patients. Okay? 100, and this is something most docs are uncomfortable asking. 100 of my male patients had experienced some or continuous erectile dysfunction. Uncomfortable talking about it. And these are sometimes young people. My CAC score range. Which primary care doctor does a CAC score on every diabetic? Should be a standard test. CAC score range from 0, which I was a little surprised by, but yeah, nice, 0, up to 3,778. And most of the patients we did CAC scores on, it was the first time they ever had that done, despite being diabetic for a long period of time. That's criminal to my mind that isn't tested for. Average starting A1C was 296 at the start, and by 5 years, the average A1C was 316. So a slight increase in A1C over 5 years, but not dramatic. Okay, and I only have data on 164 patients in that group. 180 of my 200 patients were on statins when they came to see me. 19 of these patients, when I sent them to go and get a stress test with a cardiologist, were significant enough that they underwent 19 required stents, or 19 required either stents or they couldn't be stented, and they required coronary artery bypass grafting. So they had some sort of revascularization procedure. 21 of these patients had a history of atrial fibrillation, which is something we don't often talk about, the arrhythmias. 17 were in atrial fibrillation at the start of the study, and by the end of the study, 5 were still in atrial fibrillation or would flip back into it. The majority of my patients had untreated, unrecognized hypertension. Very, very, very few of our patients check their blood pressure regularly, which I think if you're diabetic, if you're obese, that should be something you do on a regular basis. But undiagnosed, untreated hypertension, so we actually, between myself, the family doctors, we initially increased their antihypertensive medication. We prescribed until we gave them an algorithm, and as Eric spoke about the other day, I think it's going to be a very worthwhile day or a discussion about deprescription of various medications. What algorithm do you use to deprescribe? That's for another day. The meds that we use, that I use personally on these patients, Tresiba, Lantus, Levemir, are my long-actings, and Humalog and Novolog. There is Fiasp, there are a few others. These are the ones that I prefer to use in this trial. I just know them well. And this is, again, from this morning's discussion, a different point of view. 165 of my patients used, and I prescribe them, GLP-1 medications, Ozempic, that kind of thing. They either used them, not so much continuously, but from time to time they were exposed to them, and we used them as a tool to help them. The ones that we didn't use either were too skinny. BMI 17.1, you don't be losing more weight, you're going to dry up and blow away. They didn't like the effect, or they didn't believe, and I agree with them, that it wasn't needed. 54 patients started out on pumps, and some of these patients came in on the Medtronic disaster. So as soon as we see these patients, I try to get them off if the insurance companies allow us to. But 54 on pumps. At 5 years, 23 were on pumps, and I prefer Tandem or Omnipod 5. The problem with the pumps, because the pumps are set up not according to blood sugar, but according to carb loading, is it's actually more difficult to manage them properly, and they have higher A1Cs. So the folks on the pumps, we use convenience and ease of use and tolerate a higher A1C than we ordinarily would using these medications here. So that's the pump data. Think about this. You're shooting up with insulin every day, and a significant number, I don't recall the exact number, never tested their blood sugar. Okay, that's nuts. Or I think the 0 includes anybody that did it once a week or less often. Okay, and then there was a cohort that were testing their blood sugars very often, 6, 8, 12 times a day. 84 of the patients at the beginning of this trial were already on CGMs of some sort. And as part of the entry into the trial, as part of our protocol, we put our patients on Dexcoms if we can get them. So G6 we started out with, we flipped some of them over to G7s. But even with the advertisements from the CGM company, oh, you don't need to check your blood sugars, that's false. CGMs only read accurate about 11 to 15% of the time on the first 24 to 48 hours. So we do want our patients to calibrate regularly. And the entry point to this cohort was the Dexcom CGM, but it is ludicrous again to me that obtaining CGMs for our diabetics, especially our ones, is such a barrier. And a lot of them can't get them, which is a real nuisance. The starting diet, and I've still got to calculate all these numbers exactly, but the starting average carbohydrate of these diabetics who've been treated by their endocrinologist and by their regular CDE, not their keto CDE like Cheryl is, greater than 500 grams of carbohydrates a day. That's what they're eating, okay? And we estimate that that's around 55% or more of their calories. I would estimate, again, this is an estimation, eyeballing the numbers, it's probably closer to about 65 to 70% of their calories are carbohydrates. 3 meals a day, 2 to 3 snacks on average. With our eating plan, we wanted them to be on a low carbohydrate diet of less than 30 grams of total carbohydrates a day. That would exclude vegetables. And obviously not everybody is as fastidious as a lot of people in this room. People relapse. So there's a spectrum of patients who can adhere to that diet very religiously, others who really struggle. And we've got to accommodate for that when we're managing diabetes, because it's a real world problem. We try to get our patients to eat once or twice a day, maybe 3 times a day, and really get rid of the snacks. We talk about bridges there. Here's the other thing. It's about carbohydrates. A number of these patients don't live in this country. They live in India, they're Hindus. We have a vegetarian option, we have an omnicarnivore option, we have a carnivore option. And I have not seen any difference with those different diets. It's a matter of convenience, matter of religion, but one is not better than the other. It's more convenient, it's easier, but it's not necessarily better. It's how you set it up. Obviously the vegetarian is a little bit more difficult, but it can be done. We certainly use as a foundation a carbohydrate addiction protocol. So we use a substance abuse methodology when we're dealing with carbohydrates, not a diet and calories in, calories out, grams of carbohydrates protocol. It's a crystal meth protocol. And we really focus very heavily on stress management. And I think, Ben's not here. Ben Bickman's speaking a couple of days' time. He's very heavy onto cellular stress. He's turned me on to that. I think we have to recognize stress in the management of our diabetics. 22 of our 200 patients did physical activity, physical exercise on a daily basis. By 5 years, 158 were doing that on a daily basis. And that is an important part, not just to mental health management, but also to diabetes management and blood sugar management. Okay, so as we do this, I made a little note to myself, so I'm going to haul that out because my brain is full. One of the things about managing type 1 diabetes, we're all saying, oh, how can they do this? We have to have empathy for the history of diabetes and understand that this is a very, very, very new science. Very new, okay? We've got to look at 3 different stories that are interwoven like a braid. We have to look at diabetes, we have to look at insulin, evolution of the understanding of diabetes, evolution of insulin, and the evolution of blood glucose monitoring in order to establish a better and better algorithm for care. And a lot of people in this community blow that off. So let's talk about diabetes. The word diabetes, it's Greek and Latin, it goes that far back. Diabetes, to siphon or pass through, to pee it out, and mellitus, honey or sweet. The Egyptians 3,000 years ago wrote about and knew about type 1 diabetes. They understood excessive urination, thirst, weight loss, and early death. They knew type 1 diabetes. They knew it as a disease. It's been around for a long time. In ancient India, physicians, healers would use ants. And they get pee, and if the ants went to the pee, they could use that as a diagnosis for diabetes, and they could make a distinction between type 1 and type 2 diabetes. That was a long time ago. In 1776, when this country was born, Matthew Dobson, a diabetic physician, was able to begin to measure glucose in the urine at home. So already for a long time, we had a poor measurable of diabetes. And guess what he did? On his own. Said, okay, I got sugar in my urine. I don't have anything to treat it with. What's the best diet to reduce the sugar in my diet, in my urine? 65% fat, 32% protein, 3% carbohydrate, avoid fruits and garden produce. First use that I could find, Gary Taubes may help me with that, LCHF in diabetes. 1776. People usually died within weeks or months of first showing symptoms until the 1920s. So we leaped from 3,000 years ago to 1920s, no real change in death rate. Okay? So that's not that long ago. In 1889, these guys with these odd European names removed the pancreas from dogs and showed that diabetes, type 1 diabetes, was caused by something in the pancreas. The concept that type 1 diabetes is an immune-mediated disease was only really understood in 74 to 76, very recently, most of our lifetimes. So the history of diabetes is long-standing, but we're only refining it now. So let's look at the history of insulin. 1910, Shapley Schaefer said that diabetes, or promulgated that diabetes is due to a lack of a pancreatic a chemical called insulin, because he was able to identify that coming from the islet cells of Langerhans. So that's when we first understood or created the name insulin. Banting and Best and I trained in their institute in Toronto, did my PhD up there. They were able to purify insulin from the pancreas of dogs, cows, and pigs, and that became everybody knows the story, the first treatment for diabetes. But it was only in 1922 that a 14-year-old boy with type 1 diabetes received the first injection of insulin, and he was able to live for 13 years until he died of pneumonia. So that's not that long ago. Okay, that's 100 years ago. It's a drop in the bucket. Injectable animal extract insulin then was used from 22 to 1978. As a medical student, we prescribed bovine and porcine insulin, and we had to deal with all the darn antibodies and the allergies to it, but we used that routinely. Okay, that's in my lifetime, and I'm very young. The first human-based insulin was Humulin, which was identical to the structure of human insulin. Lispro, the first short-acting, was only produced in 1996. That's not that long ago, okay? So before that, we had to change our way that we managed and understood this disease. Only in 2000 was the long-acting Lantus, and you heard me talk about Lantus and Humalog as two important products that we use. Very recently, 20-something years, just over 20 years ago. Only in 1986 was the insulin pen delivery system, so you were dependent prior to that on somebody drawing up a syringe who couldn't see that well. And the continuous pumps started being produced in the late 1990s, so not that long ago. Then we look over at insulin resistance. So in 1936, Himsworth differentiated between type 1 and type 2. That was the real first time that we scientifically described that. And then Himsworth theorized that type 2 was related to insulin resistance, Eric, rather than insulin deficiency. And that insulin resistance leads to type 2 diabetes. So it's not an insulin number problem per se, it's the resistance, but if you can't overcome that resistance, then by definition, you've got a deficiency of insulin. Insulin resistance causes cells to lose their sensitivity to insulin and not be able to take in glucose. This is from Himsworth in 1936. In response, the pancreas increases its output of insulin to a peak insulin production level that is genetically predetermined. So each one of us produces insulin to a maximum threshold. And this comes from me. Some people in our practice are high insulin producers. So every time they walk past a donut, they gain 5 pounds. They gain weight very easily, but their blood sugars are normal. They're obesogenic. That's me. My highest ever recorded fasting insulin was 87 when I was fatter. Others have low peak insulin production capacity, are diabetics. So their fasting insulins, they're elevated, but they're not awfully high, and because they can't produce more. So now their blood sugar builds up because they can't clear that sugar over the insulin hump. Finally, let's look at the history of glucose monitoring, because all three of these are important. What's diabetes? Let's find out about insulin, how do we get insulin, and how do we monitor this? 1908, blood glucose levels were available to be measured by urine. The problem with that is it's latent, it's not very accurate. So when they started using insulin in 1922, insulin overdoses and lows were a problem. So what do? They set that number much higher to avoid the lows. In the 1980s, So look at that leap from '08 to '80s. Fingerstick blood glucose monitoring for home use was available on a daily and weekly basis. And I certainly manage patients as a medical student, as a young resident, according to that protocol. Self-monitored blood glucose really began in the mid-1980s, using a dextrometer with dextro sticks. And by 2010, 14, 15 years ago, SMBG technology became painless enough that people, especially with kids, were comfortable doing it. That's very recent. So we've got to have empathy for this methodology. And only once we could measure blood sugar at home could we understand the relationship between blood glucose and diabetic disease. In fact, in 1993, a sentinel study was published looking at intensive therapy where we could now use insulin to bring blood sugar down with an external pump or 3 or more insulin injections. And the conclusion was that intensive therapy effectively delays onset and slows progression of diabetic retinopathy, eye disease, kidney disease, nerve disease, and subsequently in 2006, cardiovascular disease. We knew this 30 years ago. We knew that tight blood sugar control improved the symptoms of diabetes. That was a long time ago. ADA still does not recognize that. In 1999, the first CGMs were approved, but they were only read by doctors every 3 days. 2006 CGM and to 2008, CGMs and smart pumps were used, where the CGMs and the smart pumps worked together. So that was a decade and a half ago. 2017 was when Libra and Dexcom and those, the more reliable CGMs were available. And in 2022, the G7 came about. So I've been using it for about 2 years. Some people still can't get their G7s. So, and then with people like Dorian, Keto Mojo, the use of blood ketone monitoring has been around since around 2012. Why is A1C important? Why is it important to know these numbers? Here's why. And this comes from David Diamond that you guys are here on Sunday afternoon. If you look at the risk of cardiovascular death, and this is in males and females, that risk is baseline at 1 around an A1C of 5.2, which equates to a blood sugar between 80 and 85, around 83. That's why this number is so important. 5.2, 5.3 is so important, because that's the A1C, the average blood sugar at which it doesn't contribute in excess to cardiovascular risk. ADA wants you under 7. So another very close friend of mine from then, not anymore, 1981, David Jenkins. Dr. David Jenkins, the head of the nutrition department at the University of Toronto, a devoted vegan. Now, this is 1981, so it's late 70s he's doing his work, before we really understood diabetes completely, before we had adequate blood sugar monitors, before we had decent insulins, before we could tightly control blood sugar. So David was way ahead of his time. He created, together with Thomas Wallover, this is all in Toronto, something called the glycemic index. And the glycemic index looks at, and they arranged foods on a scale from 0 to 100 to look at what foods did to your blood sugar over the course of 2 hours. So the GI is a scale to assess food based on a rise in blood sugar after 2 hours of consuming that, with pure glucose arbitrarily having a number of 100. And every food was assigned a GI. And they then created this mathematical formula where, based on the glycemic index, you could do a calculation or plug a calculation into a table and determine plus minus how much insulin you needed for that particular product. The problem is everybody's different. So what did they do? And the danger, the fear was going low. Low blood sugars were terrible, and they were killing people, seizures and death. You didn't want to go low. So what they did is they arbitrarily elevated lowered the amount of insulin you needed, which would elevate your blood sugar. And if you talk to most endocrinologists now, they'll say, oh yeah, but diabetics are different. They don't have to run like normal people. They can run a little higher. And that comes from David Jenkins. And how do I know David? He was an advisor on my PhD. He was on my PhD committee in Toronto. So I've known this guy since the 1990s. And the GI is still the standard for calculating insulin dosing before a meal or a snack, and the GI, the glycemic index, is used to set up pumps. Carb calculator. So when we're dosing insulin, the standard of care is not to dose insulin according to blood sugar, it's to dose insulin according to the amount of carbohydrates you're about to eat. That's how the pump works. That's how most endocrinologists calculate that, because of the fear of lows. I'm going to skip glycemic load. That's a more sophisticated way of calculating the amount of insulin. One thing you saw there, I flipped over it. Gary Taubes has written a brilliant book, just published a couple of weeks ago, on the history of diabetes. I would urge all of you to read it. A lot of this data comes from that book. So in 2023, that would be just a few months ago, the ADA updated their position statement saying the cornerstone of type 1 diabetes therapy is insulin replacement. And this is challenging because insulin demands vary widely according to meals, exercise, and many other factors. Furthermore, insulin doses needed to prevent hyperglycemia are associated with a risk of low blood sugar, leaving people with type 1 a tightrope to walk. Because their position, the ADA's position, is that the variable is your diet, your exercise, your stress, your blood sugar, and the controllable constant by some mathematical formula is your insulin dosing. Okay? So they've got variables, what changes, and what should be constant. And remember this. And according to the ADA, this is a table from this 2023 output. They're looking for an A1C of below 7. GMI below 7, they've got this time in range and tight time in range. That range is 70 to 180, your blood sugars. That's them. Finally, there's the current standard of care has been tested by something called advanced carbohydrate counting. So now we're counting our carbohydrates, and this advanced carbohydrate counting is a systemic method for insulin bolus calculation that is recommended. We talked about insulin bolus calculation according to carbohydrates. And these guys published several papers saying that there is no significant improvement in A1C concentration with carb counting versus the control usual care. So no matter how refined your carbohydrate calculations are, it don't work. Okay? So then the ADA also says that the studies indicated that high-fat protein meals require more insulin than lower-fat protein meals. Huh? If you're carnivore, you don't need more insulin, you need less. But here's where they screwed up. With identical carbohydrate content. Okay? Not replacing, not reducing carbohydrates, but with the same amount of carbohydrates. Because God knows you need carbohydrates for your brain, don't you? That's why my son is like he is. So the ADA 2023, there's no eating pattern recommended for people with type 1 diabetes. The nutrition approach should be individualized, blah, blah, blah. Carb counting is the most common meal plan type approach for type 1. They promote carb counting still. And additional components, they then get worried about low-carb diets. While low-carbohydrate diets, while low carbohydrates and very low carbohydrate eating patterns have become increasingly popular, and they acknowledge they reduce A1C levels in the short term, okay, because they don't have 5-year studies, it is important to incorporate these in conjunction with healthy eating guidelines, eating carbohydrates. Additional components of the meal, including high fat and high protein, may contribute to delayed hyperglycemia and need for insulin dose adjustments. Since this is highly variable, people need to measure their blood sugars for up to 3 hours, and then they also make a statement that because of this tighter treatment, people are gaining weight. Why are you gaining weight? Because you're using more insulin, and you are fixing that problem that Eric and I talked about earlier on. You're shoving that sugar into your fat cells now, which you couldn't do before. So instead of being that skinny person that dies of anorexia, like the type 1s used to do, now you're not dying anymore, you're just becoming fat. Okay. Last little bit of history. RKB. Richard K. Bernstein. 1946, at the age of 12, was diagnosed with type 1 diabetes. Started using in 1969. He started using the very, very first little insulin sliding scale, calorimetric. I used to use those as a medical student to check my patients' blood sugars. But in 1969, he had a fight, because he wasn't a doctor at that time, to acquire home insulin monitoring. He was an engineer, and he realized that tight blood glucose control was the right way to go. So he could measure his blood sugar, and he did that regularly, up to 20 times a day from time to time. I spoke to him a while ago. We were on a panel together. He said, yeah, 20 times a day. My God, pricking your finger in those days with those heavy lancets. But he became fastidious about blood glucose management and using small doses to do that. And his statement is still true, I believe. High blood sugars are the cause of all diabetic complications, and tightly controlling blood glucose eliminates complications. Today, the American Diabetes Association, high carbohydrate, low-fat dietary recommendation standard of care after especially that 1993 paper that I just talked about. So completely defying, still to this day, what Dr. Bernstein has promoted and has proven to be true. Bernstein focused on maintaining low blood sugar targets to avoid diabetic comorbidity. And this is exactly the same position that the SMHP has taken in our position paper that I would urge you to read. ADA, standard of care, maintain higher fasting blood glucose targets to reduce the risk of hypoglycemia. They're still stuck in the 1990s, not that long ago, where they're worried about hypoglycemia, which can be fatal. They used to be, but very, very seldom anymore. What's killing us now? The morbidity is multi-system neuropathy, nerve damage, and the thing that's killing us is heart attacks and strokes. I'm not a type 1, but as type 1 diabetics. So remember, I asked you to remember the variables. ADA variables, diet, exercise, and stress, blood sugar, those all go up and down. You eat carbohydrates, you don't eat them, and you control the insulin dosing. My thought when I looked at this said, okay, let's flip this around. Instead of using insulin to control these variables, let's flip this around. Let's make the variable the amount of insulin you use. And let's try to make, and this is where Eric and I are 100% in consensus, let's try to make the non-variable, the constant, the controllable, our blood sugar, our diet, our exercise, and our stress levels. Stress being the most difficult one. So let's control our diet. And then we vary insulin dosing based on blood sugar, not based on diet. And that is the SMHP goal of therapy. That's the statement right there, okay? Now, what happens when you don't do that? Chronically elevated blood glucose and high untreated spikes in blood glucose with acidosis from transient diabetic ketoacidosis causes procoagulant clotting in your blood vessels, inflammation of the blood vessels with plaque formation, waterlogging, hypertension, high blood pressure, venous clotting, and endothelial cell electrification, which causes what I call metabolic arrhythmias. Neuropathy, the nerve damage, comes from damage to the Schwann cells, and the nerves don't work properly. And then the collagen matrix, that scaffolding of every organ in the body, including your ligaments and your tendons, they get glycosylated. It damages the scaffolding of every single organ, every membrane, every ligament, every tendon, every joint capsule. A hemoglobin A1C of 5.2 to 5.3 associated with normoglycemia in the 80s ideally has no negative impact on cardiovascular neurological collagen matrix systems. And that is the goal of type 1 diabetes treatment in 2024. Why? Because we now have new tools. We understand the disease better. We have reliable CGMs. We have keto assessments. We have more accurate, easier to do SMBGs. Even every now and then, Rion falls on a needle and we can measure his blood sugars and his ketones. We have ultra short-acting and long-acting insulins. We have pumps, we have pens, and we have new drugs. GLP-1 agonists, and what's coming down the pike, the GIPs, the big one for me are the glucagon receptor agonists. And then triple combinations. Eli Lilly's producing GGG, which is a combination of all three of these. And that, I think, is going to help us tremendously in the management of diabetes. So here's another little thing other people were talking this morning about GLP-1s, liraglutide, Trulicity. This is a study done by the ADA. Trulicity added to insulin therapy, reduced A1C levels, reduced total insulin dose, reduced body weight in type 1 diabetics. Magic, 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 triple magic. Because that is the goal of what we're trying to do. Trying to reduce A1C, we're trying to reduce the amount of insulin, we're trying to get these folks, if they're heavy, to lose weight. But here's the conundrum. In this study, it was accompanied by increased rates of symptomatic hypoglycemia, drop in blood sugar, hyperglycemia, elevations in blood sugar with ketosis. And that is the ADA reason for saying that GLP-1s should not be or contraindicated for use in A1 in type 1s. That's exactly why I like them. That's why I like them. These drugs should be used in type 1 diabetics. They reduce insulin use, in my experience, by a third in these diabetics. They reduce weight, they reduce A1C, they give you stability. And they are enormously valuable. And we have studies that prove that. So what happens if you go hypoglycemic? Guess what? You lower your amount of insulin. If you're still giving yourself the same amount of insulin, but you've reduced the amount of insulin you need, of course it's logical, it's obvious you're going to go low. And this is the point I was trying to make this morning. And this is from my patient population, this is my observation. When people, my patients, eat a lot of sugar and starch, at first, they need to clear that sugar from their liver, from their bloodstream, and the way they do that is to release more insulin. So as you eat more sugar, blood sugar goes up, pancreas releases insulin, and you start to produce more insulin, and the pushback from these cells that are getting flooded with insulin is to phosphorylate, to block the receptor, to block the effect of insulin. So what does the pancreas do? It says, let's give you some more insulin. And we can test fasting insulin. I do it on every one of my patients regularly. Fasting insulin levels go up. We call that insulin resistance. Absolutely fine. But as long as your insulin production can overwhelm the resistance, you turn that sugar into fat. Your blood sugar remains normal, and you become obesogenic. And the diseases related to obesogenicity are obesity, dementia, Alzheimer's, cancer, PCOS, low-T autoimmune disease, and joint disease. However, everybody has a point at which they can't produce more insulin, where the insulin resistance is beyond that insulin production capacity. Okay? Type 1 diabetics can't produce any insulin. So what happens with them is when they eat the sugar and starch, their blood sugars go up because they can't produce a lot. They tophy, they're thin on the outside, fat on the inside. Type 1 diabetics should not be obese. Okay? And those folks have hypoglycemia, hypoinsulinemia, too little insulin. That's what type 1 diabetes is. And what we do with those people is we give them insulin. So what we're doing is recreating this. So we give them insulin to lower their blood sugar, but the consequence of that, if they're eating a regular diet, is that they gain weight. And that is the standard of care with the ADA. But at first, you want to create a leveling of the ratio between intracellular and intravascular blood sugar. Intravascular blood sugar very high, intracellular blood sugar low, with a barrier. You want to force that sugar into the cell, and then as the cell gets flooded not flooded with sugar, but as it takes up that sugar, it slowly, as that ratio gets level, and we bring that total blood sugar down, if you're not eating carbohydrates, and that's where the consensus is. If you're not eating carbohydrates, then both come down. If you're still eating a lot of carbohydrates, you're just flooding your cell, you're obesogenic. We don't want that. So you've got to get rid of the carbohydrates, but then we use insulin to correct the ratio. And as the cells then recruit insulin receptors, you then need less and less insulin. So we've got to go up to come down. And at first, what we do with type 1 management is we convert them to obesogenic. And as we get rid of the carbohydrates, we can reduce the amount of insulin that's required. So it's a two-step process. And here you see it in a schematic. So here you see someone who has very little insulin. All the sugar is on the outside of the cell, very little in the cell. And they have high extracellular sugar and low intracellular sugar. You then add in insulin, and the green dots, and you can shove that sugar into the cells. They then have a rise in blood sugar and a rise in intracellular blood sugar and extracellular blood sugar. If you then eliminate carbohydrates in the diet, we can then work back to this space over here. That's the logic that I saw a few years ago and started developing that in practice. So how do we do that in practice? The first phase is called the therapeutic phase, where you take those patients that I described in that very first slide and you treat their insulin resistance. Doesn't matter if they're a type 1 or a type 2, we're treating insulin resistance because most type 1s also have a type 2 component. In fact, just a little quote from one of my type 1s, the guy that's had diabetes for 64 years, the greatest enemy of a type 1 diabetic is their endocrinologist. So what we do is we do blood work to confirm, are you a type 1, are you a LADA? We've got to measure those antibodies because things will change over time, and we measure their insulin resistance. Yes, you can measure that. We do a comprehensive metabolic workup, and every diabetic should get a CAC score as a baseline. We then go on to fat adaptation, and fat adaptation is very different than ketosis. Yes, you can get into ketosis in a day. I can drink a bottle of ketones, or I can drink a bottle of olive oil and get into ketosis in one day. But it takes the machine between 1 and 2 years to transform. Fat adaptation takes a very long time, and we measure that all the time. We measure that. That's a blood work measurable. That's not me just guessing. There's a 15, 20 different blood parameters that we use to assess that. In order to become fat adapted, you want to be on a low carbohydrate diet. Low carbohydrate, preferably with higher fat and salt. You don't want to be snacking, and you want to get to 1 to 2 meals a day, which is our program. You want to create intentional hyperinsulinemia to lower blood sugar. So we actually increase insulin as needed according to blood glucose to even out the extra intracellular blood glucose ratio. And these folks won't necessarily lose a lot of weight, but their blood sugars are going to come down. So if you say, I've been doing this for 12 weeks, but my A1C hasn't moved, that's because you haven't been aggressive enough with your insulin. Okay? And you may gain some weight. You may not, but you're not going to lose a lot of weight. And what we do there is we use a long-acting insulin, Lantus, Levemir, Tresiba, twice a day. Basal rate. And I'll show you how we do that in a second. And then we use the short-acting insulin anytime you are 10 milligrams per deciliter, 10 points higher than what we call a set point. So that's our program right there. We use CGMs. We put the insulin pumps into sleep mode because you now start getting increase in insulin at a much lower level of blood sugar. We use the keto mojo to make sure we're not in ketosis, in ketoacidosis. We will use GLP-1s to block the glucagon paradoxical hyperglycemia. Because what's happening is your cells don't have enough sugar, so they send a message to the liver saying, "Dude, we need more sugar." So what does the liver do under glucagon? It dumps sugar into the bloodstream, so you get paradoxical hyperglycemia. And then we do the self-care, physical activity, and the psychology of addiction is very, very important in this. So we use the CGM to determine the average blood sugar, 188, or monitor blood glucose levels. We use an LCHF consistency equivalent. I don't care why your blood sugar is high. I don't care if you went for a run. I don't care if you're stressed. I don't care if you ate a tub of ice cream. Treat the number. The only number that matters is your blood sugar, and the only thing we treat is your blood sugar. Treat the blood glucose number. And if the ADA could do that one thing, they would completely change the management of all types of diabetes. Treat the blood sugar. Okay? Our initial basis is to find a target range. So if your average blood sugar is 188, we set a target range of 140 to 160. And we use a 2-day average on the CGM. So at your 48 hours, why do we do a 48 hour? It flattens any spikes. It flattens things out. So we use a 2-day average blood sugar. Prior to each dose, we check our blood sugars, and then if you are in that range, you give a prescribed dose by your physician. If you are above 160, you add 1 unit to the dose. If you're below 140, you subtract a unit. So the first step is to get into this range. And you can use the short-acting insulin anytime you are 10 points above that, except you don't want to give it more than every 2 hours because you don't want to stack. Very, very simple protocol. And then what you do is once you're effectively in that range and you're not adding or subtracting insulin, guess what? Then we lower the range. We lower it to 120 to 140. And now you find you go up on your Tresiba dose or your Lantus dose until you're back in range. And then we lower the range and we lower the range, and our final target range is a blood sugar of 85 to 97, but you're going to be using more insulin. Got to go up to come down, even if you're getting rid of the carbohydrates. Short-acting doses over there. Insulin pump we use to sleep mode. And we use the GLP-1 and agonists to lower the liver blood sugar production and to lower your consumption if you're struggling. You don't have to use it, but it's an incredibly valuable tool. And if you're eating enough protein, muscle waste doesn't happen. Then we go, once you've gotten to that point where your blood sugars are 85 to 97, some folks even run lower. I've got some folks that run in the high 70s. But they can be very tight because you're not dropping your blood sugar, you're preventing rises. That's a change in thinking as well. The danger for hypoglycemia is you drop your blood sugar by a big bolus. No, we're just flattening the rise. Okay? So we use a long-acting sliding scale and short-acting doses for events, whether you're angry, whether you've had a run or whatever it may be. Anywhere from an omnicarnivore to a carnivore, or even a vegetarian option, maintaining this eating pattern, that should become a way of life. And we intentionally induce then hypoinsulinemia. So this is what Eric was talking about. But that's on the back end of going up to come down. Because as people become more insulin sensitive, you need way less insulin. That's what the ADA couldn't wrap their heads around. So we radically reduce insulin utilization using the same sliding scale. Now, I've got some people, some of my type 1s are using 2 or 3 units of long-acting insulin twice a day. Pathetically small amounts. Some of them hardly ever dose the short-actings because they're good with this. We use the CGM pump, and then we have to work with adrenal and physical activity responses. I'm going to skip that slide. So this is my penultimate slide. So where's the proof? I told you about those 200 patients we studied. Here's their results. If you look at, and this comes from something called Phil Schauer did this trial, the GREEN trial. That is standard type 1 diabetes management. So when you first diagnose them, they get better, and then by 5 years, 60 months is 5 years, they've gone back up. But look at this, the average blood sugars, ADA wants you at 7. They're up in the 8.5 range at 5 years. That's not 7, but that's using standard management. This is our protocol, the protocol I just described. Starting A1C, 8.9, slowly dropping down, 6.5, going up on insulin. I don't have the insulin slide here. That'll be in the paper that we publish. 6.5, 5.7, 5.1, 5.0. Remember, 5.2 is your target. And this cohort at 60 months, average A1C of 5.3 with a range of 4.5 to 6. Not a single diabetic in that group if diabetes is diagnosed as 6.5. That is what you can achieve through diet, low carbohydrate or no carbohydrate diets, and treating blood sugar. If you treat your blood sugar, you don't have cardiovascular disease. If you don't have cardiovascular disease, you don't need a statin, but statins don't even work, in my opinion, if you do have cardiovascular disease. So I just throw that guy in there. Because more and more cardiologists are going to focus on diabetes, not lipids, as the causative problem of cardiovascular disease. So we know, we now have, golly, I couldn't spell. We now have more and better tools. We have better insulins, better agonists, better ancillary drugs, better blood glucose monitoring. We have the tools, and they're going to get better. We need not, and this is the crucial thing, we need not fear hypoglycemia. It is measurable, it is defendable, especially if you're in ketosis. Ketosis will protect you against the effects of low blood sugar, and it is treatable. So we don't have to fear this. We're still trapped, most doctors are still trapped in the fear of hypoglycemia that comes from 30 years ago because we didn't have the tools. We do need to fear hyperglycemia, high blood sugar. That's the enemy. And we need to treat it directly, irrespective of cause. The best form of blood sugar control is to not put crystal meth into your body. And that's where we have complete consensus. The best fuel for the body is fat, and we need as a society to get rid of lipophobia, our fear of fat. Fat is human. We need to understand and treat insulin resistance by understanding that it's okay to increase the amount of insulin up front to come down. Treat the insulin resistance. The constant should be blood sugar. The variable should be insulin dose. That's what my body's doing right now, all the time. That is exactly what my body's doing. Keeping my blood sugar fairly normal, a bit of rise and low here, but keeping it very constant, and the dose of insulin my pancreas is giving me is the variable. And I'll make this statement, that when properly treated, especially if you've got a young child with type 1 diabetes and you start early, type 1 diabetics ought to have a longer lifespan and be healthier than non-diabetics, because they can measure and treat. I have to wait for my pancreas to react, and my pancreas is resistant. It ain't working so good. Diabetics have all the tools and the capacity to be healthier and live longer than me. So please go ahead and read the SMHP position statement on therapeutic carbohydrate reduction for people with type 1 diabetes. Here's your call to action. Know it, share it, and live it. Thank you.